Okay, welcome everyone to the Jousse lecture series. My name is Damien Manzo. I'm a postdoctoral fellow here, a postdoctoral researcher here at Kite, working with Dr. Jose Zarifa, and I'm the host of the lecture series. Really excited to present today Bronwen Moore, who's an occupational therapist with 24 years of experience working in the field of neuro rehab and pain management. She holds a Bachelor of Science in Occupational Therapy from the University of Toronto, a Master of Arts in Adult Education from Ontario Institute for Studies in Education.
You're muted.
We can't hear you.
I'm back now. Thank you. Sorry, everyone. We'll start again. So we'll just kick off the Jousse lecture series. I'll just go straight away to introducing Bronwen Moore, who I was saying is an occupational therapist with 24 years of experience working in neuro rehab and pain management. She holds a Bachelor of Science in Occupational Therapy from U.T. and a Master of Arts in Adult Education from Ontario Institute for Studies in Education. In her work with Toronto Rehab, brain and spinal cord living engaged and actively with pain, so the LEAP service at UHN, she supports people with neurological conditions and pain to learn skills to self-manage their pain and find creative ways to do the activities that clients value the most. She holds an Adjunct Lecturer status appointment with the University of Toronto Department of Occupational Science and Occupational Therapy, and she's presented at numerous conferences about topics related to neurological rehab and pain management, and her research interests include pain self-management, healthcare worker self-care, and resilience, and the role of arts in healthcare. Okay, so without further ado, Bronwen.
Thank you so much, Damien, and thanks everyone for being here. So it's my absolute pleasure to be here today to speak with you about a project that's very dear to my heart. This is our research study evaluating the impact of our pain management group that the LEAP team had developed and how it works for our clients who live with neurological conditions and persistent pain. So thank you, Damien, for that introduction. This is me, and I'm really just here representing a big and wonderful team who all came together to do this work. So it's my pleasure to speak on behalf of all of us. I don't have any conflict of interest to tell you about. You might notice that I mentioned a YouTube channel and a book which are revenue generating. However, the funds from that goes to our account with the UHN Foundation, not to us personally. And here is that big and wonderful team. So this project was only possible by a whole lot of people coming together and pitching in. So we're really happy that we can, I can speak on behalf of all these great people. I want to particularly mention Sarah Shep, who designed this study and got it rolling way back when we started, and Debbie Hebert, our late principal investigator. We miss her a lot. She brought a lot of light and clarity to the project, and we do continue this work with the support and encouragement of her family. I would also like to acknowledge some people. So thank you to CAP for the funding of the grant. Thank you also to the UHN Foundation for funding support. And our former manager, Allison Freeman, a student Sydney, who really helped us move the manuscript forward. And of course, all the participants for their time and effort, without whom there'd be no project at all to tell you about. So here is our plan for the next 40 minutes or so. We'll start by talking about that connection between spinal cord injury and pain. We'll talk about the evidence of why pain self-management can work for this population. We'll tell you about our group that we designed to teach people these skills. We'll go through the results of our research study evaluating the treatment program. And lastly, we'll have some practice tips that we hope might be of interest to especially those folks coming to us from the clinical side for working with pain and spinal cord injury. And just so that I can manage my time, I'm going to ask folks to hold their questions till the end. And my colleague, Kara Kircher, is kindly attending online, monitoring the chat, so she'll see if things come up there in the meantime. So let's begin by setting the scene around spinal cord injury and pain. So here are some definitions of pain. We know pain is our most complex sensation, and it's always unpleasant, it's always subjective, it always brings on emotions. And we know that pain often starts out as a helpful mechanism to kind of get the body to protect itself from harm. However, when it goes on for a long time, that can change and it can start to limit function and well-being. And that's often when my team gets involved to support people to kind of build their skills to improve their function in the face of pain. Looking now at pain and spinal cord injury. The estimates of how many people who have spinal cord injury live with pain varies a lot depending on who you ask and how you ask them. But here's a meta-analysis that brought together a bunch of studies, and it put the rate at around, just under 70% overall. So the vast majority of people that you see with spinal cord injury live with pain. And the most common kinds are neuropathic and musculoskeletal, and oftentimes a combination of types. And at level, below level of lesion and back pain are also the most commonly heard of ones. We know pain matters, first of all, for obvious compassionate reasons, right? And even beyond that, we know that pain makes it harder to recover from a spinal cord injury. Studies show that people living with severe pain do not get as much therapy as others because of their limited tolerance. We also know that it adds impairments, right? Functional impairment, psychological impairment, and it disrupts cognition, which makes it harder to learn all the many things you need to learn in order to live well with a spinal cord injury. So lots of reasons to do what we can to support in this area. So let's just talk briefly about how persistent pain can develop. So anyone can develop persistent pain, but we do know there's a few risk factors that make it a little more likely or a little riskier. So certain types of thoughts can contribute to that risk of developing persistent pain. And I particularly want to highlight expectations because we as healthcare providers do have a responsibility for setting expectations. So we always encourage people, being told not to move by a healthcare provider is one of the risks for developing persistent pain. So please, if you advise someone to restrict movement, have a plan for how you're going to wrap that up at the right time. Make sure they know how they'll know that it's safe to move again. And they can lift that restriction as soon as possible because it can really make a difference. We don't want people carrying these restrictions a moment longer than they have to. Also, obviously, those dealing with emotional comorbidities like depression and anxiety may be a greater risk. Certain behaviors, and again, I want to highlight the fear and avoidance of movement. We'll talk about that later. But it's very natural to fear and avoid movement when there's pain, but often movement is what will help. So finding a way to work with that is really important. And again, as healthcare providers, we have that opportunity, right, to help people through that, figuring out how to move in ways that feel safe to them. Also, folks, pardon me, with a complicated life, right? People who have a lot of demands on them, people who may not have as many social resources perhaps to bring to that challenge of learning to live well with this condition may be at greater risk. So all this is to say, if you are working with someone, you feel like they may be at greater risk, it's a great opportunity to support them to build this skill set. So let's talk a bit now about some evidence for why pain self-management education is worth the while. So there is lots of evidence out there looking at pain self-management education with pain for all reasons, right? Broadly defined pain. Lots of studies on that show that it helps people with their long-term function, their health, their psychological status. The evidence is more of it in an emerging state with spinal cord injury, but it is recommended by the Campaign Spinal Cord Injury Clinical Practice Guidelines, so that's a good step. And also, there's a few studies that have shown that this kind of education can help folks with spinal cord injury improve things like their sense of control, their participation in activity, their mood, their life. And I want to point out that one of the references I have here is our own Dr. Burns here at Lyncher Center. And this study was actually, going back about 15 years or so, my team had developed a precursor to the group I'm talking about today, and this study looked at how that worked for people with spinal cord injury right here at Lyncher. So it's kind of neat to come full circle back to that. So lots of studies show pain self-management education works. It's effective, it's cost efficient, and just to demonstrate that, my team is 2.4 FTE. We're 2 OTs and a physio, and we serve about 100 patients at a time. We offer about 2,000 visits a year with that resource. So it is a really great way to get help to a lot of people in a short time. And we know the self-management education boosts all kinds of things we'd like folks to have more of, like self-efficacy, persisting with tasks, function, and it decreases things that can be challenging, like anxiety, for example, and even very measurable things like use of hospitalizations, use of medication for pain, that kind of thing. And self-management interventions often teach a variety of coping techniques, so just like the ones shown here on the screen. And as you'll see in a moment, our treatment program draws in a lot of these options and forms. All right, so now I'd like to explain the treatment program that the study is evaluating. So we call that the Pain Management Group, or PMG for short. And the way that this group came to be developed was my team had been running pain management services for people with pain for all reasons for many years. And in 2014, 2015, we stopped and we redeveloped to really focus in on the unique needs of people living with neurological conditions, including spinal cord injury, injury, stroke, multiple sclerosis. And because of their unique learning needs, the barriers they face accessing care, so that we kind of retooled everything. We looked at the research, we pulled ideas from there. We interviewed clients and clinicians working in the field. We thought a lot about how it was going to work logistically, and we kind of created this group. Since then, we've been doing a lot of kind of constant revision. We're always trying to bring in feedback and improve it and edit it. And we're now in that last phase of evaluating. So this research study I'm talking about today was a big part of that. How are we going to show that this, are we going to know that this works? How are we going to show, what it can do for people? So you can see that the start date was way back in 2015. And that is why I would like to show you this mole. This is our team mascot for the project. And trying to bring this project to completion was very much like a game called Whack-A-Mole. If anyone's not familiar with it, in this game, plastic moles kind of pop up through holes, and the player has to try to thump them with a mallet to make them go away. And that kind of was our feeling for this project. We felt a little bit like that mole. It seemed like, we would just sort of get a good, the first 2 or 3 years we had a lot of momentum, and then it seemed like we would just kind of get going, and then something would come along and derail things, whether it was, a loss of key personnel or a wave of the pandemic that came along, and we'd all get redeployed and have to come back a few months later and pick up the pieces. So it was a constant lesson in patience. So just the fact that I'm finally here today to talk about this, feels incredible to my team. And so we have put a lot of mole-like patience and persistence into this process. So let me tell you now about the group that we're evaluating. So this group meets once a week for 2 hours over a 9-week period. This slide shows all the topics that we teach in the group. And so each week has a theme, and we have various activities around that theme. So week 1, understanding pain. We talk about pain science, how pain works, to kind of decrease the fear of the unknown that's part of living with pain. Week 2 is called Doing What Matters, and this is about helping people reflect on what's important to them in life, because that can really change after a health event. And how can they find new ways, more creative ways perhaps, to connect with the things that matter to them, even in the face of all the changes that they're experiencing. And we often bring in ideas like pacing here and adapting activities. Week 3 is about stress management and relaxation. Pain is stressful, and stress aggravates pain, so we try to help people build their toolkit for that. Movement and physical activity is huge. Having people move in safe, sustainable ways that they can do long term is a huge part of their recovery. We talk about sleep. We could all benefit from more rest. We talk about how to work with thoughts and emotions around pain. And the assertive communication session is always fun. We talk a lot about how to ask for help, how to set boundaries and set limits. You may have to say no to more things than before in order to have the energy to do the things that matter to you. And lastly, how do you plan for pain flare-ups? Because even when things are pretty stable or even improving, pain flare-ups come along. So we need to be ready with some quick, easy access tools and tricks that we can draw on. I will maybe just mention here, if anyone's listening from outside of Toronto Rehab Brain and Spine, that at this time we only take referrals from inside Brain and Spine. So we often do get a question about how to refer. So if you're within Brain and Spine, I will tell you. But if you are not, unfortunately, that door is not open at this time. So here's the key elements of each group session. We open with a relaxation practice, which is a great way to get folks kind of settled in, let go of their day, kind of clear their mind, get ready for learning. Then we teach a little bit about the topic, kind of the science behind it, give them a moment to connect it to their values, why it might matter to them personally. And then we talk a lot about what they can do about it, as much as possible bringing in discussion and peer support from their colleagues in the group, because I think they, folks living with pain teach one another in a really effective way. It's very powerful. And we always have a movement break with some gentle exercise so people can develop that habit as well. And this shows the lead team's breakdown of the diagnoses that we serve. And now this is not the sample of the study, this is more of a 10-year overview from our own records. But just to show roughly the populations we serve, it's about a third of people with brain injury, a little less than a third with spinal cord injury, and the other third is made up primarily of multiple sclerosis and stroke. And you'll see when I talk about our study demographics that it's pretty similar. So a key part of our program is building in adaptations for cognitive changes. And this is really essential because many of our clients do have brain injury, and that may affect how they learn. We also know that, all of our clients may experience cognitive changes as a result of their pain. And I will mention that spinal cord injury and brain injury are often comorbid. Again, estimates vary, but it's not up to 30 to 50% of people with spinal cord injury may also have a brain injury. They may not be diagnosed. It's often thought to be undertreated, usually mild brain injuries, and more likely within the cervical spinal injuries. So this is a good thing for all of us to be aware of, because it can be, make it a little harder to learn things that one needs to. So some adaptations we built in to work with this are, we have our workbook, and I have a couple copies at the back for the folks here in person. And it allows people to follow along, to read at their own pace, and there's lots of worksheets with checklists and options, because our clients with brain injury told us open-ended questions can really tire them out. So having the checklist with options right there means they can just check them off, and it's a less cognitive load for them to have to work with in that moment. We also have multiple ways of learning, so we use videos and memorable stories and experiential practice and so on. As much as we can to get those messages home. We repeat key skills and messages, and we encourage them to review independently. And since the time of this study, we have made some changes. We've pivoted to virtual care since the pandemic, which has actually been a change that's really opened our doors to more people. We published a workbook, so at the time of the study, the workbook lived in a binder, and was very much an in-house product, and now people can access the workbook from wherever in various formats, including the Toronto Public Library. And our online presence has also grown. We have our YouTube channel, which I can show people at the end if they're interested. And its channel name is Leap Service, and it has a number of videos with gentle chair exercise routines and guided relaxations. So feel free to explore that. All right, so now we've got all that context, let's talk about the research project. So this was a mixed methods study, so bringing in that quantitative and qualitative aspect, looking at the impact of our pain management group on psychological and functional outcomes for people with neurological disorders and pain. And this is a step towards, we hope, one day disseminating this model to other facilities. And we want to tie this in as well with the Canadian Pain Task Force recommendations. This was a huge initiative at the national level to change how we understand and treat pain in Canada. And we believe this really ties in with that idea of ensuring equitable approaches for populations that are disproportionately affected by pain. And while spinal cord injury isn't mentioned in the document, I believe that they are a population disproportionately affected by pain. And so serving them is an important way to fill a gap. So looking at our methods, of course, the Research Ethics Board was on board. We recruited people over a one-year time period at their intake interview, which is a standard part of practice. They come in, we assess them and see what they want to do in terms of treatment. We got written consent from everybody, and our design was pre and post test. So we actually measured at 3 time points. Time 1 was at their intake interview, sometimes we call it T1. Time 2 was at the end of the group, and time 3 was our 4-month follow-up. So if we could track them down at that point, it was a nice chance to see if the change was maintained or not. And we had hoped to get around 60 people. We got 53 that we used there. That does exclude one person who withdrew entirely from the study because they were too busy to continue. Of those, 44 people joined our pain management group, and 35 attended enough sessions that we considered them to have participated in that treatment. 33 people had full data at time points 1 and 2. But only 9 had full data at that third time point. We did experience a big loss to follow up at that point. And that also includes partial data from 2 people who withdrew midstream in the study because of medical and social crises unrelated to the study. We did include their data, though, up to the point where they left. So these are the outcome measures we used for that quantitative piece. The Canadian Occupational Performance Measure is probably familiar to many of you clinicians, so it looks at how people do with a goal that they've set for their function in terms of self-care, productivity, or leisure, and they rate their performance with it, their satisfaction with that. The numeric pain rating scale is your classic 10-point scale, right? Rating your pain from 0 to 10, 10 being the worst, and we asked them about that in the last week, best and worst. Then there's the pain catastrophizing scale. This looks at kind of the thoughts and feelings they may have around pain. And pain catastrophizing, this measure has been used in tons of studies, and it's considered a risk factor for persistent pain. Then we have the chronic pain acceptance questionnaire, which measures pretty much what we figured. And then we have the SF-36, which looks at health-related quality of life. And so higher scores here are associated with positive outcomes. Looking at the analysis, so our main exploration was comparing time 1 to time 2, because that's where we have most of the data. And so they did repeated measures, ANOVA, some paired t-text, and exploratory analysis, mixed effects modeling, all kinds of things, looking at that comparison of time 1 and time 2, and also using data imputation to kind of bolster that data at time 3 to look for trends there. We did, earlier in the study, hope to have a control group, but as it happened, we weren't able to kind of recruit and retain enough people who were willing to participate but not to receive care, so we had to let go of that piece of it. And we also did a short qualitative exit interview as people left the group at time 2, so I'll talk a little bit about that too. We analyzed that using constant comparative analysis, and 3 of us participated in that one. So here's our demographics. We had 44 participants. Most of them were in their late 40s. A little more than half of them were female. And in terms of diagnoses, we were tied for most between spinal cord injury and brain injury, about a third each. And the remaining people had, again, primarily stroke and multiple sclerosis. So very similar to the demographics we see for our service at large. Most had been living with pain for around 5 years, and luckily, many of them actually completed 8 or 9 sessions of the 9-session group. So most of them actually got a really meaningful opportunity to engage with us. So as I go into the numbers here, I do want to be very upfront about my own limitations regarding statistics. So I will do my best to represent the work of my wise colleagues who I'm so grateful to them that they can do this. But if anyone has more technical questions, I will pass them on to my colleagues. Laura, Ella, and Edie are the ones who get all the credit for the numbers here. So this table shows the comparison of outcome measures between times 1 and 2. And you can see, I know this is probably really tiny, and I apologize for that, but over here we have the p-value that looks at statistical significance, and these ones in yellow were all statistically significant findings. So, and you'll notice that the reliable change scores are also fairly large. So looking at those quantitative results, just to summarize, change happened. People generally improved on the measures we asked them for. All except for the numeric pain rating scale, and we had not hypothesized that this would change. Studies on self-management programs don't tend to find change here, and that's because we were working with acceptance of pain, living well with pain, rather than eliminating pain. So it did trend in the right direction, but not to that level of significance. And we want to particularly highlight our Canadian Occupational Performance Measure, because this was our main clinical measure, looks at function. So again, this one looks at how people do with a goal that they've personally set for themselves in terms of their function, and you can see that between kind of the pre-group and the post-group, time 1 and time 2, there's not just a statistically significant change, but also a clinically significant one. A change of 2 points is considered clinically significant, and we're well over that threshold, so that made us happy to see. So now I'd like to get into our descriptive analysis. So this is where we had to do some data imputation because we didn't have a lot of data at time 3, the follow-up point. So spaghetti plots were created to show trends in the data, and we wanted to see how people changed after the end of the group, whether they were able to hold on to those changes they made, which would suggest that it was a lasting change. So in terms of this, there's a trade-off between power and precision, and this method gives us more power but less precision. But we did have good power at the time too. Something weird is happening with my mouse. There we go. Okay. So this spaghetti plot looks at the performance rating for the whole. People set on the Canadian Occupational Performance Measure are looking at how well they can do a chosen activity. So if you look at the graph, this is time 1. We see improvement to time 2, and then we see maintenance to time 3. So that's what you want to see, right? People, were able to hold on to the gains they made. And the way that spaghetti plots work is it shows the individual trajectory of each participant. So all those 8 lines are like one person, and they're plotted like a separate noodle in a bowl of spaghetti, and the average noodle is that one that we're highlighting, and it shows the trend, and it has a 95% confidence interval highlighted around it. This also looks at that goal, COPM, and people's satisfaction with it. So again, we're seeing things improve during the group, and then the maintenance of those gains. This looks at the acceptance of chronic pain. So again, trending in the desired direction. This looks at the pain catastrophizing scale. So again, this is looking at how the distressing thoughts they have around pain. So you'll notice the line goes down, and that's good. We want to have less of pain catastrophizing if possible. And lastly, here's our SF36. That was the health-related quality of life measure. So you can see that, again, it improves and holds steady. So we were happy to see all that happening. The last part of that quantitative analysis was an association analysis. So we used some linear regression models to look at how various outcomes, the outcome measures, would change, looking at time 1 to time 2 here, with 5 risk factors we've chosen. So age, gender, diagnosis, the years they've been living with pain, and how many group sessions they attended. And we didn't find a whole lot, basically. So there were no particular associations with gender, years of pain, or how much group session they attended, so which is good. It means there's a general sense that the group is, broadly beneficial to those who attended in the same ways. There was a slight association with age, so older participants gained a bit less in terms of acceptance of pain. And there were no differences between those with spinal cord injury and the other diagnoses, which is nice to see that, again, they can benefit just as much as others from this format. All right, and here's our qualitative results. So again, we analyzed this using the constant comparative method, and these were the themes that came up. People talked about those experiences with the group format in particular, the importance of peer dynamics, and how they were using the group content in their daily life and goals. So looking at the group format, people talked about the things about the format that worked for them, including the workbooks, the way we teach about pain, even the movement breaks came up. People also talked about some barriers, travel being particular. One, a lot of people talked about how difficult it was to get to appointments with the pain, with the expense, the inconvenience. And so I guess something that's followed since the pandemic is we now only offer this group virtually. So that particular barrier is no longer there. And I'll just read a quote. Somebody spoke of, I liked reflecting back on last week. I liked the movement break and the option to step out if preferred. I enjoyed the videos and the facilitators worked well together. We were interested to see this theme. A lot of people talked about peer dynamics and how much they got out of being together to learn with other people with spinal cord injury. People talked about self-worth that they got from that and the decrease in isolation. So for example, one person said, I like speaking in small groups because sometimes I feel isolated, so it was great to find others who could relate. There's a sense of comfort in sharing tips with others and giving advice, almost like a family. And the last theme spoke to how people are applying the content they learn to their daily life. And so, for example, here's a quote, I decreased my pain medication use, now I'm using more strategies from the group, I need less meds. So it's good to see people really running with what they have learned and making it their own. So of course we have limitations, the delay in analyzing and getting the project kind of to this stage. It's there. Also the lack of a control group. If we were to do this again, we'd love to have more of a meaningful control group and a better follow-up at that 3rd time point. So kind of summing up about the study then, we hope that this intervention shows potential, right? It shows the possibility to promote meaningful change for people living with neurological diagnoses and pain, helping them in pain catastrophizing, acceptance, quality of life, and how they do with their function. And in terms of future research, were we to have the opportunity to do this sort of thing again, I think we would be curious to compare this group to the virtual version we're running now and see how they line up. Also compare it to a control group and to follow it for longer so we can see, how these gains change over time. All right, so I want to use our last few minutes here to talk more about the practical tips. So for those working with people with spinal cord injury, here are some ideas for how to work with pain and support clients to self-manage. So first of all, some general tips. We encourage you to always ask about pain. I think sometimes we may hesitate to ask because we don't have all the answers. So we just want to offer that idea that it's okay not to know. It's okay not to have all the answers here. It's still really helpful for people just to hear that you're listening and that when you bring your curiosity and your interest to it, it actually is very, very helpful to people. And if you can ask about functional impact, sometimes the pain may be showing up in particular parts of their life, particular things they want to do, and that can be an opportunity to really zoom in on it and work with them around some problem solving. It's good to acknowledge, just validate their experience and be curious. And if you have motivational contributing background, it can be really useful here. And also just recognizing that practice is essential here. So the types of changes we talk about are lifestyle changes that can take a while to really sink into people's lives. So it's good to practice those key skills and recognize that neuroplastic change does take time. So it's gonna be a while. It's a little bit slow moving, but the benefits can really add up. And so you see our little type A turtle here. That's our team mascot. And so we encourage people to proceed like a very persistent turtle. Lots of patience on their journey. So these are our top pain coping strategies that we want to briefly explain to you here. So first of all, teach people about how pain works. Again, when people know more about pain education has been shown in studies to decrease their fear and increase their function. So just understanding the kind of complex and confusing symptoms can be a big relief to people. And so some examples, if you have time and in the comfort level, you could explain about how pain works in the nervous system, and I'm about to show you a couple of visuals that we use for that work. Also, you might help them to connect between the areas of their central nervous system that was injured and the pain experience, because that might help them to make sense of what they're feeling. Also, the concept of hurt versus harm is really useful here. And we talk about harm, we often assume pain means we're in danger, right, that our tissue is at risk. But sometimes pain is just, it's hurt, right? It's there in the background. It represents enduring changes from all we've been through. But we may be able to safely persist through that. And so when people can tell the difference, and that can take a long time to figure out, when people can tell the difference, they have the information they need to make choices, right? Skillful choices about whether to persist with something or whether to back off and respect that limit. And so there's a lot of great evidence-based resources you can offer to people who want to learn about this. I want to particularly shout out to Spinal Cord Injury Ontario. Their resources on Portree on this are really great. So there's a link there that you can Google them. And here's one of the visual aids we use sometimes when we're teaching about pain science. So you can see there's a picture of the brain and lots of different little points of light in there. And those are all areas that pain signals or danger signals go to. And so we like to talk about how, when a pain signal reaches the brain, it's processed by many, many different brain areas that actually have to work together to create that experience. And this can kind of help account for the complexity of it, right? So you'll notice the pain signals are going to our movement centers, right? And telling us not to move. It says stay still so that we don't get hurt worse, right? Which makes a lot of sense in the first few days or maybe weeks after an acute injury. But if you're months, years later, and that instinct is still there to stay still, that can kind of get in the way when movement is maybe what you need at this point in order to progress. Also, pain goes to those emotional centers, right? And pain is naturally an emotional experience. It uses those emotions to motivate us to change our behavior and get safe again, or at least it's trying to. But it helps to validate for people that's part of why pain has so many feelings attached to it, and why sometimes working with feelings can influence pain. We also talk about how pain goes to those frontal lobes, right, where we do our more complex thinking. it's a real magnet for attention, right? When pain is happening, it's hard to think about anything else, and it can be very distracting and disruptive. So we talk about how, again, that's part of the experience, and also it's an opportunity, right? Because pain is so complex, that means there's a lot of levers you can pull to make change here. And a really great quote that I think we took from Laura Ramos, that I can't remember, but is that pain changes everything, and everything changes pain. So it's kind of a hopeful message, right? There's so many things we can do that taken together can add up to make real relief over time. The next strategy we want to highlight for you is that idea of taking a break from the pain, taking a short break. These tend to be strategies that give you relief for a little while. And I'm always hearing clients discount these, say, oh, you know, I'll do a massage or whatever, but it only works for a little while. So we really want to highlight the value of that. Actually, just knowing you can take a break is very empowering. And we liken it to the experience of if you had to carry a heavy load around all day, right? It would really wear you down. But if you could just put it down for a second and shake out your arms and then pick it back up again, it wouldn't be so bad, right? And so strategies like this are really great for giving people that short break that they need to kind of restore their energy and feel ready to continue through their day. And also, these breaks allow a powerful opportunity for neuroplasticity, right? If our brain isn't constantly firing on those pain pathways, it has the opportunity to do other things, and maybe to grow up some competing pathways, stop some competing neurochemicals. So there's good reasons to do this. And so here are some examples of strategies people may use to take breaks. Things like distraction, right? Our brain is not great at multitasking, so if we can make it do something else, it's harder for it to process the pain. Medications are great here, things like heat and cold, you know, massage, short rest breaks, you know, all these things can really be helpful for short breaks from the pain. And this is, sorry, my laser pointer is developing the light that's on here. Interesting. Okay, there we go. This tends to be the strategy that I find people tend to discover on their own, or to maybe have more background knowledge of. So oftentimes people have already figured out that distraction works, or that heat or cold works, and we can encourage them to lean into that, right? If that's worked for you before, fantastic. How can we do that here in the hospital right now today, if it's safe for you? And this is an analogy we use when we teach people about the power of distraction. So this is an orchestra. And we like the analogy of the pain experience being like an orchestra working together to play a song, right? That's like the many parts of the brain and nervous system coming together to create this experience of pain. And now we may not be able to stop that orchestra from playing, right? They're determined, but we can change the song, right? If we can just even distract a couple of violins or get the drum person to go off and take a break, you know, the song will be different. And so that's that power of distraction. And if we can get the orchestra mixed up a little bit, then the song is not going to feel the same. It's not going to sound the same. So now let's look at strategies for calming the nervous system. This matters because the pain signals can come across as kind of a constant message of danger, right? And people may find that they have a great deal of difficulty ever feeling safe or relaxed because the pain signals are kind of constantly putting their nervous system on alert. And so knowing how to send themselves cues of safety is really important to balance and regulate their nervous system to get into more of a parasympathetic state. And so some examples of these strategies include, you know, social connectedness. Again, that's where that peer support is so useful, right? Sleep, being able to rest, using the breath can be an incredible way to modulate our stress response. You know, gentle things with stretching, movement, guided relaxation, meditation, practices with self-compassion, and even nature connections. That's a beautiful thing here at Lyndhurst. You have nature all around you. And so people can, you know, get outside and really connect with that side of themselves and may find some relief there. Also creative activities. You know, there's so many things that can help us to get cues of safety. And often when I'm talking about this with a client, I'll say, what do you do to unwind after a stressful day? Like, what helps you to change gears? And people often already know a few things that work for them. And they can build on that. This is a moment where we do want to mention the idea of being aware of trauma, right? So it's a good kind of universal practice to keep in mind that any client we work with may live with the effects of trauma. It may not be from this health event, it may not be diagnosed, it may just be kind of something that they're not as aware of. However, it's possible that anyone could have trauma. And of course, it's not up to many of us to treat that directly. However, we can all help people participate more fully if we create an environment that allows them to be successful. So think about what we can do to make the environment feel safer, right? Can we deal with visual clutter? Can we deal with noise? Can we be predictable? Can we have routines? This is always how we do it, so they know what to expect. And we remind them of their autonomy, right, and their control, that they can always say no to anything, that they can take breaks when they need to. And they always have an option to ask questions, right? And all these things taken together can really help to deliver service in a way that feels safer. And also knowing that, that's part of the magic of groups, right? When people connect to one another, when they teach one another, there's a real opportunity there to turn trauma into thrive. So that is there to think about. And the last strategy we want to highlight for you is all about challenging that pain with some gentle activity. So helping people to build up their exposure, their tolerance for uncomfortable experiences in ways that feel safe. So gently engaging with pain through movement or other activities is really powerful here. And this is where graded or gradually increasing physical activity is fantastic. You may partner with someone who can, kind of help them with the psychotherapy aspects of that process if necessary or helpful. Pacing strategies are great here to help people kind of gently engage with pain at a pace that feels reasonable and sustainable to them. And having a flare-up plan so that on those occasions where we do overstep the safe limits, we know what to do, we can immediately put that into place and we can feel better sooner. And this slide shows that cycle of the fear and avoidance of movement, right? It's a real risk with persistent pain. People very naturally and very quickly learn to avoid things that are painful. It's just how we're built, right? It's a survival instinct that has served us well in many cases. But the difficulty when you live with pain a lot of the time is that that fear of pain can come to apply to more and more activities, and people may find there's less and less things that they feel safe to do. And at that point, they can start losing conditioning, their life satisfaction can decrease. So if we can work with people to help them learn, not to avoid all the challenges, but rather to find safe ways to face them and engage with them, we can really help to reverse this cycle. And so we offered you the phrase, nerves that fire apart, wire apart here. So if we can help create situations for people where pain is not happening, the brain can unlearn those associations. So progressing gently with our activities so we're not pushing into pain flare-ups, using those pacing strategies so people feel in control and can take breaks. And novel situations are great here so that people have a blank slate, right? They have no expectations what this will be like. And so it's an opportunity for them to learn something with an open mind. All right, so that's the end of our strategies. I wanted to just wrap this up with a quote from a past lead client, not a study participant, but shared with consent. So she said, I realized that my life could go on despite the pain. I learned it was not all outside my control. I learned I had the power to change the way I thought about pain and reacted to pain. And although I can't always make the pain go away, there are things I can do to make it easier, to make it better or easier for myself. So we hope that kind of shares, the function, that the way people can change how they approach life and do more of what matters to them. So as we close, pain is common after spinal injury. This kind of education seems to have promise that could help. So I want to thank you all so much for your time and attention. It's been great to speak to you about this. And we have a few minutes now. If folks do have questions, I'm happy to do my best with them. If anyone's attending online, Kara is there monitoring the chat. And opening the floor.
Yes, hi.
Go for it.
I have two questions around outcome measures. So I know the list of ones that you measured, was that just for the study, or are you doing any outcome measures as part of your regular participation for LEAF participants?
So at the time, that was our standard practice. However, since we pivoted to virtual, it's really limited how we can engage with people through outcome measures. So at this point, we're kind of limited to what's in EPIC, which is for anyone who's not familiar with it, is our electronic health record system. So at this point, we're using the pain self-efficacy questionnaire as our primary outcome measure.
So that kind of leads into my second question. So as a PT, our normal, we do ask about pain as part of our assessment, but our normal scale for monitoring is the numeric rating, but you're saying that doesn't seem to carry much weight. So what is the best outcome measure that maybe maybe not the best, and that's hard to say, but what would be a better outcome measure that we could utilize?
Gotcha, yeah, good question. So just for anyone online who couldn't hear that, the question is what kind of outcome measures can we be using with people around their pain? And so I will clarify, the numeric rating scale of pain didn't shift to a significant degree with our study, with our intervention. That's not to say it wouldn't change for you with what you're doing, because you're doing something else, presumably. So I don't want to discourage you from using that one. I think it has the advantage that everybody knows about it. So it's kind of a universal language that you can speak, and it's quick and easy to do. I would say sometimes choosing a measure focused on your particular goals can be helpful. So like we used to use something called the Pain Stages of Change questionnaire back even before this study, and I really liked that one because it looked at, are they in the contemplation stage, thinking about change but not ready to go yet, or have they shifted into action? Now they're doing things, they're actively working in their life to promote change, or are they in maintenance? And you could kind of see where they were at with readiness. Sometimes a functional goal can be a good indicator as well because it's a little more something a camera could see, which is helpful. That experience of pain is so subjective that sometimes it's hard for people to remember or describe it. So I like the COPM or another functional goal because it's, is it happening or not? In your life, how is it going? And sometimes it's a little easier to see that happening as an indicator that pain is maybe less of a barrier than it used to be. Okay, does that help a little bit?
Yes, thank you.
Okay, good pleasure. And COPM is an epic then. Yeah, it's just hard to.
Dr. Ferland is raising her hand
Oh,
online.
thank you.
So I'm not sure if
She can unmute herself.
Yeah,
Okay.
Dr.
We'll be able
Ferland,
to
we see you want to ask a question, and we'd love to hear it. Do you want to try unmuting? We'll see if we can hear you.
Hey, hello, can you hear me?
We can. Go for it.
Hi, Bronwen, good to see you. I'm here at the University Center.
Thank you.
Love your program, yeah, really good. My question is about what kind of patient, or better, what kind of pain do you think responds better to approval? You may not have the answer to that, but there are different mechanisms of pain. Not all chronic pains are the same. You may have, especially in spinal cord and neurological diseases, you may have a mix of nociceptive pain, a mix of neuropathic pain. But in my practice, the majority are none of those. They are nociplastic pain. And I find that some of these strategies work really well for some types of pain, but not for others. And for nociplastic pain, we are using pain reprocessing therapy, which is kind of a, very new, but also old, because there's nothing old in this world. Everything is renewable and recyclable. But did you think about what kind of pains you are putting in your group? And would you do something different in kind of a triaging them? Because if you have a group of only majority neuropathic pain,
Thank you. Yeah, good question. And I feel like you've got a study there. You've got something you could really dig into there, which would be neat. Unfortunately, that was beyond the scope of our study. We didn't explore in this project the particular reasons for pain. And what we tell people when they come in is the strategies we teach, there's something here for everybody, right? There's something that will work for whatever type of pain. I do agree with you that it's hard to have pain without nociplastic pain to some degree, right? Like anyone who's experiencing pain, whether it's musculoskeletal or neurological, we believe that there is a tendency to develop nociplastic pain as well. So I think those strategies can be useful regardless of what brings people here. So we try to focus on function as much as we can and kind of dig into like quality of life stuff more so than the mechanism of what's happening for them.
I see. And yeah, it's just in my experience, we are separating them because we do treat them differently. We are trying to do things that work better for nociplastic pain only for people who have nociplastic pain. But yeah, just a suggestion for you to consider this in the future.
Thank you, I appreciate it. And again, we've been really enjoying watching what your team is doing, and we're watching closely to see where you go with the pain processing therapy. It's something we're curious about. Thank you for the question. I see a couple of other hands up, one in the room and one virtual.
Yeah, sure, I'll go.
Sure,
I was gonna, it's very related to the previous question, so maybe it's relevant. I was just wondering, I know with the association analysis, you're saying that none of this stuff really changed in terms of diagnosis, but in the qualitative piece, did you get any unique perspectives across diagnoses? Like, did the SCI group care about something more in that program versus the ABI group? Did you get anything?
That is a really great suggestion. We did not look at that, Damien, and now I really wish we did. That would have been awesome to know. I will say in the association analysis there, I didn't speak to it today just because I've only got 40 minutes, but there was a slight difference in the MS group of clients with MS. There was a slight difference, I think, in terms of how their performance or satisfaction of their functional goal was a little bit less of a change than the other diagnostic groups, and we wondered if that was because it's our only potentially progressive condition that we're seeing. Again, I was trying to focus on spinal cord injury here, so I didn't go too much in there. But yeah, I agree. The qualitative piece, it would be neat to see if there was a difference there. Maybe next time.
Awesome.
We've got another decade to go into a research study, and we can go there. Thank you. Okay, and I see a hand from Dr. Berlin.
Yes.
Please go ahead.
Yeah, thanks so much. It was a great presentation. I really appreciate you sharing your project, which was wonderful. I'm particularly interested in terms of the association between pain and sleep disorders. I have been studying in the field of spinal cord injury. I just finished a study, and I thought there was going to be an association between a higher degree of sleep apnea and neuropathic pain, and unfortunately we did not find the case, which is one way that you could manage it. But my question to you is, in your own impression, do you think a particular sleep disorder would be more associated, such as chronic insomnia, which is common in all these neurological disorders that you mentioned, or do you have any insights about what kind of sleep disorders could be more associated with pain motivation?
So I'm just going to say your question back to you because I'm having a bit of difficulty hearing. Forgive me.
Yeah.
I think, were you asking, did we look into what kind of sleep disorders our clients were experiencing?
Yeah, so my question was related to this, and the question was more in terms of if you find that chronic insomnia is more likely to be the one to be blamed in the modulation of chronic pain in this population, which is a common neurological sleep disorder, and also in the general population in this particular group that you are managing with chronic pain.
Thank you so much for clarifying. Yeah, so we agree. We didn't look into it in this study, but we agree that insomnia is the disorder that we target in our education about sleep strategies because it is, you know, the numbers are just huge. People living with chronic pain are at very high risk for that chronic insomnia. So, and also it's often lifestyle change is one of the things you can do, and that's what we have to offer people is strategies for, you know, really practical day-to-day changes for lifestyle. So yes, we are. Our strategies are catering to that we teach for sure, and I'm excited to hear about your work with this area. I look forward to hearing more about it.
Thank you so much. I appreciate that.
Thank you. Okay, I recognize it's 12:59, and
One more question,
you want
Bronwen.
to go. So if anyone does need to go for it. I'll take one last question from our online community. So thank you. Go for it.
So this is a question from the chat from Natasha. She says, the study sounds really interesting. Is it published? If so, may you please share the citation? Would love to read more. Thank you.
Oh, thank you so much. So we actually, I'm very excited. Our manuscript it's ready. It's been a really long time to get that over the finish line. So we're planning to submit it to the Canadian Journal of Pain for consideration. My research group partners have until Friday to tell me otherwise. So if I don't hear a no by Friday, it's going in next week. So hopefully, fingers crossed that they will like it. In the meantime, there is a citation just for our abstract, because we presented this work at the International Association for Brain Injury Conference in Montreal last year. So there is an abstract citation that I can certainly post. I think I can put it, if I put it in this meeting chat, I think people can access that after the fact. So I'll try that. And if it doesn't work, my team's email address is there, leap@uhn.ca. Feel free to reach out there if you'd like, and I can also send it to you through email.
Okay, let's thank Bronwen again.
Thank you. Really appreciate everyone's time and attention.